Welcome to today's webinar. We are continuing our series on basic infection prevention for new and experienced IPs in the critical access environment. And today we're going to talk about the environment of care, particularly with regard to environmental services and what you need to know as an IP. So let me scroll through here. So I'm representing Qualis Health today, and so I'll be the speaker. We are the EQuIP, the Quality Improvement Organization for the states of Washington and Idaho. And our funding comes from Medicare to help support this program and all of the quality improvement projects that we work on. So today, hopefully by the time we get done, you'll be able to describe the general principles of cleaning and disinfection of healthcare surfaces. So we're not going to really talk a lot about how to actually do a terminal clean or anything like that, just the basic principles, what you need to know as an infection preventionist in order to be able to assess those practices and make sure they're as safe as we can make them. We're going to talk pretty extensively about the advantages and disadvantages of different types of disinfecting agents that are used in hospital settings. We're going to talk about how to assess and evaluate cleaning methods, what are the evidence-based practices that are currently available. And then we'll talk a little bit about some of the innovative cleaning technologies like UV and hydrogen peroxide fogging and things like that. So I do want to remind you that the slide set was sent out yesterday for those of you who were registered at that time. And if you did not receive the slide sets, let us know and we'll be happy to send them out to you so you can study, if you'd like, from the slides. So let's talk about why environmental services and housekeeping are really important in hospitals. So if you're an infection preventionist for any length of time, you're going to get this question all the time. That is, well, how long does X organism live in the environment? Well, the answer to that question is depends. And hopefully as an IP, that's the answer that you're giving. Because as you can see from this graph, the key pathogens that are organized here, MRSA, VRE, Acinetobacter, C. difficile, you can see there's a wide range of how long they survive on surfaces. And a lot of that depends on the temperature, the humidity, is it wet, is it dry, is it in organic matter, is it in a spore form? So it really does depend. But I think the key message here is that many of these organisms can survive a long time on surfaces, and it's really important that we make sure that we are cleaning those as often as we possibly can. Now, even though they exist in the environment, does it really make a difference if you have these pathogens on your surfaces with regard to the transmission of infection? So here's a study that came out in 2011 from Shaughnessy, who really talked about C. difficile and the risk of a patient getting C. diff simply from being in a room that was previously occupied with a person who had C. diff. And this is an important study because it's fairly large, more than 1,700 patients, and this is in a tertiary hospital in an ICU setting, but it still is very important information, and that is that they looked at patients who were admitted to the ICU, and they tested them for C. diff within 48 hours of admission, and then again, they checked back 30 days later. And 4.6% of the patients who came down with C. difficile had not been in a room previously occupied with someone with C. diff, but 11% of the people that did have C. diff were in a room previously occupied with someone with C. diff. So twice as likely to come up with C. diff if the room was previously occupied. So what they're saying, these authors came up with was that even when you control for all the other risk factors we know for C. diff, including the patient's age, their physiological condition, the Apache score, their exposure to proton pump inhibitors, and even their antibiotic use, when they control for all of those, it was still significant that the patient was in a room that had been previously occupied with someone with C. diff. So this is huge. This is really huge. This slide that I'm showing you now comes from Bill Rutala's site. So I just kind of listed this part from him, but I've given him credit down below. But C. diff isn't the only thing. I mean, when we look at the risk of acquiring a pathogen simply from an environment that was occupied with a person with disease. You can see whether it's MRSA, VRE, multi-drug-resistant Pseudomonas, C. difficile, or multi-drug-resistant Acinetobacter. Rutal is saying there's 120% more likely chance that someone will come down with these if they were in a room that was previously occupied. So again, this is why we're talking about environmental services. The evidence is really starting to show that it contributes significantly to disease transmission, and therefore having a really good, comprehensive, effective disinfection program is essential for your environment. If you are an infection preventionist, whether you're in a large hospital or a small hospital, there are some specific things that you're going to be responsible for with regard to housekeeping and environmental services, namely product evaluation. You really do need to know what products are being used and on what surfaces in your hospital. So hopefully you are on your product evaluation committee and that you have some say in what gets selected and purchased, and that you can help evaluate that. The other thing that you're going to be responsible for is helping to evaluate how clean those surfaces are, this objective measure, in order to understand what the risks are to your patients. You may also be responsible for actually providing infection prevention orientation or training to new housekeepers, or the annual training that may fall to their manager, but you want to make sure that they're getting appropriate infection prevention training. And then, of course, anytime you're seeing an outbreak, which is defined as an increase over the baseline of any particular infection, don't forget the role of the environment in transmission. So you'll want to be able to do an assessment of the environment and housekeeping in doing an outbreak investigation. Now, we can't talk much about disinfection without going back to the Spalding classification. We've talked about this before, particularly when we worked with Virginia Mason on a previous webinar, where we look at how do we classify surfaces, whether they're on devices, instruments, bedside tables, bed rails, that sort of thing. And we look at the Spalding classification as how is that surface being used. So if it is something that is going to enter sterile tissue or a vascular space, that needs to be sterile. We consider that a critical instrument. That's usually what we're going to send through the autoclave. If it's something that's going to come in contact with non-intact skin or mucous membranes, we're going to consider that semi-critical, and at the minimum, it needs to be high-level disinfected. Now, what we're talking about today, though, is the non-critical. That means this is surfaces that come into contact with intact skin. So bed tables, bed rails, light switches, nurse call lights, TV remotes, those kinds of things are non-critical surfaces. We're also talking about equipment like blood pressure cuffs, the x-ray machines people touch, the controls on Dynamaps, those kinds of things, any that's a high-touch surface there. So let's talk a little bit about product terminology so that we can really understand what each of these products are, because this is really confusing. And you guys have been with me for a while. You heard the story that I told about how I got into infection control. And just as a reminder, it was one of those where I had made a small med error on as a nurse, and then just a few days later I was asked to take the infection control role, and I really did think that it might have been punishment for the med error. And the reason I really believed that it was punishment was because my first week on the job full-time as infection prevention, I had to go to a meeting, a 3-hour meeting, where all we did was talk about phenolics and quat-ammonium compounds and OPA and glutaraldehyde, and I just thought, oh, this has to end soon, otherwise I need a new career. However, I will say that all of it was really important, and even though I didn't understand it at the time, hopefully I can help you today work through a little bit, so if you get stuck in a 3-hour product evaluation meeting, you'll at least know a little bit about what they're talking about. And we start by the terminology. So there is a difference between detergents and disinfectants. Detergents are, they have a surfactant in them, which really does help break the surface tension between soil and the surface it is adherent to. So it doesn't disinfect, but it will help remove visible soil. A sanitizer will reduce bacterial contaminants, like you'll see on the label, 99.9% of bacteria will be removed. And normally when we talk about sanitizers, that's like food industry. So you'll see that in products that are used in kitchens and some other food areas. A disinfectant, though, is EPA registered, and it has to meet certain criteria. And we're going to talk a little bit about that in a few minutes, about how do we know it's an effective disinfectant and at what level. And the definition of a disinfectant is something that destroys the pathogens, but not necessarily spores. So it's going to get it it's antimicrobial in a lot of ways, but not necessarily kills the spores. An antiseptic. Now, sometimes we'll hear antiseptics and disinfectants interchanged, but they're not interchangeable. Antiseptics are what you use to disinfect the skin. Alcohol is one of the very few antiseptics that can be both a disinfectant and used on skin. I mean, we're going to talk more about alcohol, but if you're thinking about chlorhexidine and some of those other things that are used for cleaning the skin, those should not necessarily be used on surfaces as well. So keep that in mind. And then you'll hear people talk about sterilizing the surface. And we don't normally sterilize a countertop, obviously. But there are liquid chemical sterilants that, for example, glutaraldehyde, if you leave something soaking for like 20 hours, it will effectively kill all living microorganisms, rendering it sterile. But for these surfaces, they do not need to be sterile, and there isn't any real way to get them sterile. But you do need to know the difference in these terms. OSHA is going to require that you maintain a sanitary work environment, particularly free of blood and body fluids because of the bloodborne pathogens. If you get surveyed by CMS or the Department of Health, it's Joint Commission, there's a whole chapter on sanitary environment or the environment of care, which has a lot of regulations about how to clean, how do you know it's clean, and making sure that the environment itself is safe. The two main resources as an IP you're going to want to look for are these, the CDC HICPAC guidelines. The first one is the Guideline for Environmental Infection Control in Healthcare Facilities from 2003. This is one I mentioned in our last webinar. It's very large, it's very detailed, but there's a whole section on environmental services that you'll want to pay attention to. The second one is the CDC HICPAC Guideline for Disinfection and Sterilization in Healthcare Facilities from 2008 by Rutala. Provided the links for both of these documents here for you to look at. There is a section on disinfection of healthcare surfaces in this 2008 guideline that you'll want to look at as well. And it has some nice information about each of the products that are the pros and cons in that section. So you'll get a lot of good information there. And I've taken some of it out for this presentation, so we'll go over it in just a minute. Now, we're not going to talk a lot about what kind of training you need to provide for your housekeepers, but I did want to let you know that there is the Association for Healthcare Environment that offers a certification for your environmental services professionals. And I think if you, as an infection preventionist, even in a small hospital, recommending certification, at least for your environmental services manager, is an important step in making sure that that entire department has the latest guidelines, the best practices, lots of good free education when they're a member of this association. And, of course, that certification makes a huge difference in their career potential. So do encourage your leadership to support this professional association for your housekeepers. Lots of good information on their site as well. First thing you really need to know is that cleaning and disinfecting are two separate steps. Many of our disinfectants they're inactivated in the presence of organic material. So you can't just dump disinfectant on blood or fecal matter or emesis or anything else that's on a surface. So you have to actually physically remove that matter before you can disinfect it. So that is the key to all cleaning and disinfection. Now, cleaning is defined as that mechanical removal, physical removal of visible dirt, soil, other debris that you can see, and that it's going to require quite a lot of friction. So keep that in mind. That's the key to effective disinfection. Also, when you're watching your housekeepers or you're trying to assess the practice, you really are looking for a systematic approach to cleaning, whether it's routine cleaning or terminal cleaning, looking at isolation rooms. You're watching to make sure that the cleaning progresses from least soiled areas to most soiled areas. And the reason we do this is that we are concerned about cross-contamination. So, for example, if you're watching or if you're doing this yourself and you're cleaning the bathroom, you wouldn't necessarily clean the bowl and then go to clean the flush handle, right? Because then you've picked up the germs from inside the bowl and transferred them to a high-touch surface. So you want to go from least soiled to more soiled so that you're moving in a direction and not cross-contaminating. The other thing you want to do is move from a high surface to a low surface, and this has to do with dust, because when you're dusting, particularly the high areas, that dust that contains a lot of funguses and molds and other things that live in the dust, they will fall to the lower surfaces. And if you've already cleaned those areas, you may not go back and remember to clean them again. And why would you clean them again? So we say move from least soiled to more soiled, high to low. So clean to dirty, high to low. Those are the main principles we want to instill in you as an infection preventionist. The other thing is I want to say that there is no product out there that is perfect for every surface that you have in your hospital. I've been doing this a lot of years, and I see a lot of products, and not one of them is 100% okay for every single surface that you have. I wish it weren't the case, but that's true. So you have to know for each of the surfaces that you have and whatever equipment you're cleaning, what does the manufacturer recommend? And you need to follow those. Now, this is another reason why you want to be on your product evaluation committee, because when you're purchasing an item, it's much easier ahead of time to ask the manufacturer for their guidelines on how to clean while you're still negotiating than after you've purchased it. Because we do want to standardize our products to the best of our ability, and in the process of negotiation, some of the manufacturers will certify that the products that you're already using are safe on their products. But after you purchase it, they may be a whole lot less willing to do that for you, and there may be a very limited or narrow scope of the product, safe cleaning products that can be used on their surfaces. So, again, product evaluation committee is the place you need to be so that you can get ahead of it. The other thing is you have to follow the instructions for use on the cleaning solution itself. So whether you're using a detergent or a disinfectant or any other product, it's really important that you read those labels. So you have to know if you're using it the right concentration. Does it need to be diluted? What is the wet time? Can this be applied with a cotton fiber, or does it need to be, some other application? Is it sprayed on? What kind of personal protective equipment is required? You must follow the instructions. This is something that surveyors love to pick up on. So if you have a surveyor in the house, they're going to be watching that everybody follow the manufacturer's guidelines. And we have already talked about use appropriate PPE. The other thing is I want you to think about this. Are there surfaces that are just really tedious to clean or impossible to clean? And if so, are there barrier devices or protective coverings that you can use? I mean, the thing that comes to mind for me is the keyboard covers that, like if you have an electronic health record where the computer stays in the room, are you using a keyboard cover? Because cleaning each of those keys can be really tedious. And then, of course, you need a policy on how are you cleaning or discarding that protective barrier. But it is an option for those surfaces that are really challenging. I want you to think about cleaning the room, dividing out the patient zone into two areas. So the high-touch areas, and these are defined by CDC, and I've got them listed here, and then other surfaces. And it's important to think about how these are separated, because the high-touch surfaces, those are the ones that are going to get mostly contaminated. They're also the ones most likely implicated in disease transmission. The other surfaces, like the floors, the walls, the windows, that kind of thing, the vertical surfaces, We don't see a lot of disease transmission from those areas because the pathogens don't readily adhere to those areas. Now, you may see the floor is a horizontal surface, but we also know that the floor is not a major risk factor for HAI transmission, believe it or not. So when you divide these out and you're thinking about should I use a disinfectant or just a plain old detergent, it's okay to use a detergent on the floors and not necessarily disinfect the floor unless it's in an isolation room. And there are good reasons for using detergents whenever you can because they can be more environmentally friendly. They tend to be non-toxic. The odor is more pleasant than disinfectants. There's much fewer respiratory reactions to plain detergent, and they're pretty cheap. So if you can move to a detergent whenever you can, that may be a really cost-effective way to get things clean. However, the high-touch surfaces and the surfaces that are in an isolation room, you do want those truly disinfected. Remember the difference between a detergent, which just removes the visible soil, and the disinfectant, which actually kills the pathogen. Now, really quickly, I want to go over a few things that you want to be aware of with regard to housekeeping. Now, we talked a little bit about cross-contamination, and this is important for you to be watching for if you're going to be doing an assessment. And again, that's going from a low area to a high area, or from a place that has got more soil using the same rag and then moving to a cleaner space. Are the housekeepers performing hand hygiene appropriately? That is, moving from an area of where it's fairly soiled back to a cleaner area? Are they changing their gloves, getting a new rag? Really watching for the prevention of cross-contamination. Another concept we want to talk about is microfiber. Microfiber is relatively new. I'd say it's been around in healthcare probably 10, 15 years. A little bit different from the regular cotton fibers that we use to do environmental services and cleaning. Microfiber is it's a really tightly woven polyester or nylon textile. And I'm not an expert on it, but I'll just explain a little bit what I know about it. And they're tightly woven, but the whole idea is that the way they're put together, they increase the surface area. So whereas a regular rag gets saturated pretty quickly or can pick up items off of the surface, the microfiber has 100 times more surface area and can pick up and hold more debris than a regular rag. Also, the microfiber tends to have a positive charge on it, so it will actually attract dust to it. So you can see that. There are some drawbacks to microfiber, though, like they have to be processed with themselves. Like you can't just throw microfiber into the laundry with other things because they do collect a lot of dust. You'll get them full of lint. And you need to, as an infection preventionist, it's important for you to work with your environmental services manager to routinely inspect the microfiber cloths and mops that are being used. Because if they're really full of lint and other debris, which they do attract and they lock into all those little folds that are in there, they aren't going to be as effective in disinfecting the surfaces and getting them clean. There's a couple of really interesting studies with microfiber that showed that even with just detergent, microfiber did a much better job of removing most of the pathogens compared to a regular cotton wipe. Now, of course, once they added disinfection, that difference went away because of the disinfectant itself. But if you just want to use less disinfectant, microfiber may be an option for you. The other thing about microfiber is you can get color coding systems, and this does seem to help quite a few environmental services people with the cross-contamination. So you can designate, say, red microfibers to clean bathrooms, or orange microfibers that are only used in isolation rooms, and green microfibers that are used in regular rooms, and maybe blue that is operating room. And that way what you're basically doing is you're segregating the cloths to a certain type of environment in order to prevent cross-contamination. So there's a lot of really fun things with microfiber that you might want to look into. But again, the drawback is that they can be kind of expensive for making sure they get laundered. Product labels. Make sure that your products, this is the disinfectant detergents, are all well labeled. So this is another concept that you're going to want to spot check occasionally. Sometimes the housekeepers have to mix their own disinfectants, so they're diluting them according to the label, but you want to make sure that the right product and the concentration and the expiration date are on the label as required. The reason we do that, and I'm going to skip ahead here to one bullet, and that is the contamination of disinfectants is a major problem. So you're going to see that Pseudomonas, for example, lives in a basic quat fairly easily. So there's some resistance to these pathogens. And then when the housekeepers top off, so they've created, maybe it gets down to the last third in the bottle, they'll go create some more and they'll just pour it in on top. But if that lower third is contaminated, now you've just contaminated the entire bottle by topping off. So we don't ever top anything off, and when you do get down to the bottom, what you should see is that they are emptying it appropriately. I mean, if it has to be neutralized or if there's some other regulation around how that particular product gets disposed of, that's being done appropriately. But emptying the bottle, thoroughly washing and cleaning and scrubbing the bottle and the nozzles, and then allowing it to fully dry. Because if they pop the top on it and it's still wet, then you're going to get some mold and some fungus growing in there, and then you have contamination the next time you use it. So that's something you're going to watch for, particularly if you're seeing an outbreak or something else that may be associated with a waterborne pathogen. Check to see what's happening with your products. Contact time, that is, you'll see that listed as dwell time, wet time, contact time. Basically, this is the concept that says on the label that the product needs to sit on the surface for a certain amount of time in order to be effective. This can range anywhere from a few seconds to 10 minutes to 30 minutes, depending on the product and what you're trying to clean. We do know from the literature that most of the disinfectants used nowadays are effective with 1 minute contact time. However, if you are being surveyed, the expectation is that you will follow the manufacturer's guidelines on the label. So if it says 10 minutes, you probably want to make sure that it stays wet for 10 minutes, even though you know that probably 1 minute is sufficient. So those are some things to think about. The cleaning schedule is really important. You want to make sure that your housekeepers do have a good cleaning schedule, that you know what gets cleaned on a regular basis. So what gets cleaned daily, what gets cleaned weekly, what gets cleaned monthly. How often are you cleaning isolation rooms? What does the terminal clean look like? And even within the cleaning schedule, do you have a good process? Are those mapped out in writing, like how to approach the room? Again, I'm going to go back to clean to dirty, high to low, that the rooms are cleaned in a systematic way so that everything gets touched on a regular basis. Now, there are some things, and we won't go into a lot of detail, but think about mattresses and pillows. Those should all be protected in a moisture resistant material so they can be easily cleaned and wiped off. Make sure that there's no cracks, tears, or permanent stains on those items. If there are, they need to be repaired immediately or sent back. If you rent beds, like for example the big boy beds or the special mattresses for people with very delicate skin that you have to rent, as an infection preventionist, make sure that there is a very good decontamination process in place. So prior to the bed coming in and then before it leaves. You really do need to know what that process is and make sure that it's being followed appropriately. Also know what does nursing do, what does housekeeping do, and the delineation of who's cleaning what. Privacy curtains are a huge thing. The guidelines say privacy curtains should be changed on a routine schedule, but it doesn't really say what routine is. However, we do know that the AHE guidelines say on an isolation room that the privacy curtain should be changed at terminal cleaning, although CDC has not really made a recommendation for privacy curtains other than cleaning on a regular basis. So that's kind of a special thing. But do know what your cleaning schedules are and what the policies are for your housekeepers. Now, last time we had a webinar, people really did like that we had some quiz questions in here, so we've included about 6 of them throughout the presentation. So here we go. This is our first knowledge check. The key to cleaning and disinfection of environmental surfaces is A, the use of specific antiseptics for each surface, B, the physical removal of visible dirt, organic material, and debris. C, assignment of trained staff to each department. Or D, the maintenance of equipment used for cleaning. So over on the right, the poll has opened. Make your selection that you think is the right answer to this question. And this question does come from the CIC study guide book from EQuIP. It's got permission to use a couple of these so that we could really check our knowledge, make sure we're on track here. All right, so our poll has ended, and in just a minute we'll see how you guys scored. But let's go through the answers and get the rationale here. So the answer is B, the physical removal of visible dirt, organic material, and debris, which we already covered because, again, organic matter can inactivate a lot of our disinfectants. A is incorrect because we said antiseptics aren't used on surfaces, so keep that in mind. On C, the assignment of trained staff to each department, that might be a great way for efficiency, but it isn't really necessary to cleaning of the surfaces. And then D is the maintenance of equipment used for cleaning. That is important. That really, really is important. But in this case, the better answer is B. And it looks like 57% of you chose that. So that's great. So hopefully the answers made sense. Now here we go. One more. I can change the slide. There we go. All right. So here we go. We're going to check again. An infection preventionist conducts an audit of the operating room cleaning process. The action that would be most concerning to you would be A, that the OR is terminally cleaned at the end of each business day. B, that the decontamination process starts on the floor of the OR and works upward toward the lighting. C, that the cleaning solutions are prepared at the beginning of each day. Or D, that a wet vacuum and a microfiber mop head are used to clean the OR floor. So take a minute and see which one of these would be most concerning to you as the infection preventionist when you're watching the OR terminal cleaning process. All right, so while we're waiting to see how the results are, the answer to this one is that B, the decontamination process started on the floor of the OR and worked its way upward toward the lighting. Again, we know that the floor, especially in an OR, because they get a lot of blood, they get a lot of fluids, everything on the floor, and then you're moving your way up, that's a problem. Again, we always like to do high to low, and mostly for the dust, but in the OR, some other things. And it looks like most of you got that one correct. OR, it's terminally cleaned at the end of each business day. That is a true answer, so not particularly concerning. C, the cleaning solutions are prepared at the beginning of each day. Depending on the label and how that works, that may be totally appropriate. And then CDC does recommend that a wet vacuum be used in the OR floor during the terminal clean, and that microfiber mop heads are actually another option for the OR. So very good. Thank you very much for that. Now we're going to talk about product selection. So this is the part that hopefully it won't feel like punishment to you, but we'll try to go over it pretty briefly so that we get a better understanding. You do need to know what surfaces you're trying to disinfect. How dirty are the areas? Are the products and the bugs, you want a good match there? So is there a lot of resistance or non-resistance in the surfaces that you're trying to clean? How dirty does it get? This is really what we're looking for when we look at products. So think about this as kind of a framework, especially if you're on the product evaluation committee. Hospital disinfectants. Now this is interesting, and this took me a while to figure out, and that is the high-level disinfectants, the OPAs, the glutaraldehydes, and the liquid chemical sterilants that are used to clean endoscopes and lumen devices and all of those things. Those are regulated by the FDA. But the regular disinfectants used by housekeeping is regulated by the Environmental Protection Agency, and they're regulated as pesticides. So that's really, for some reason, that interests me quite a lot because there is this difference in who regulates. But in order to get registered with the EPA, each of those products has to meet certain minimum standards through lab testing, and they have to submit those to the EPA in a fairly rigorous process before they can get approval for that product to be sold as a hospital-grade disinfectant. And they can't put information on the label that like it works against MRSA or it's effective against norovirus unless they've proven through laboratory testing that that's the case. So anytime you're purchasing a product, make sure you look for that EPA registration number. You can look that up, and there's various sites that you can look up the number, and that will give you more information about the testing of those products. So a little bit about EPA testing. Tuberculocidal is a classification of disinfectants, and it's the minimum standard for hospital-grade disinfectants. So they tend to be effective against the HIV, hepatitis B virus, hepatitis C virus, because those are more fragile than the Mycobacterium bovis, which is the bacteria tested in the laboratory on tuberculocidal products. So if it's effective against BCG and it has to achieve a 4-log reduction, then it is considered tuberculocidal and can be used in a hospital. They use a proxy test. So a lot of people think, oh, it's tuberculocidal, so if I have a patient with TB, I can use this product. Yes, you can use the product, but keep in mind that TB is not transmitted through the surfaces. It's an airborne. So even if you clean the surfaces, you still have a situation with the air. So just keep that in mind. It's a little misleading with that. So that's tuberculocidal claim. Now, new is a sporicidal claim, particularly against C. diff. And this is a hot topic because everybody is looking for something other than bleach to work with C. diff. And there are a few things out there right now. But to get a sporicidal claim, the product has to be tested on a specific strain of C. difficile, which does produce a toxin. It's listed here. And if you know this about C. difficile, it is an obligate anaerobe. Those of you, my microbiology colleagues, know more about it than I do. But when they're testing, they have to maintain records that the C. diff didn't die as a result of being exposed to an aerobic environment, but that they maintained that. So it's pretty rigorous. Most of the claims are for killing C. diff on hard and non-porous surfaces, and so not the fabrics that we're worried about, but for the actual hard surfaces, and that they're looking for a 6-log reduction in 10 minutes. Now, right now on that list, which we call List K, which is the list under the EPA, those are all the C. diff sporicidals. Most are still bleach products that have been approved, although you will see some hydrogen peroxide and combination products on that list. So I encourage you to look for those as well. All right, so now I'm going to go through a few of the most common disinfectants used in hospitals. This is the kind of the boring part. Keep in mind that these are, when I talk about the advantages and disadvantages, these are for pure products. What you're going to see are combination products most likely. So many of these products are going to be combined with alcohol or maybe some other accelerant, and so you can get advantages of each when you do that. But in the pure form, alcohol, we've already talked about it being both a disinfectant and an antiseptic. It is quite bactericidal, fungicidal, and virucidal. It won't kill the spores, though. However, you don't use it to clean surfaces because it evaporates really, really quickly, and there's a lot of variation in the time to kill with alcohol depending on the surface and the pathogen you're trying to get at. And there's a lot of different concentrations. So the big thing about alcohol is that it evaporates too quickly for large surfaces, and it's very flammable. So you want to be very careful about that. But also it's not great for rubber and plastic and some other things to make it really hard and crack. So that's some advantages and disadvantages of alcohol. Hypochlorites and other chlorines, the main product here is the household bleach. It is sporicidal, which is a great advantage, and it is very broad spectrum, which makes it a fantastic disinfectant for a lot of different things. And it's really cheap, and it works pretty fast. However, if anybody has spilled bleach on their clothing or the carpet, you know that it's going to damage those soft textiles. Hypochlorite, it loses its potency pretty quickly, so it does need to be mixed up at least every 24 hours, and you want to keep it away from light. and it doesn't work and play well with others. So it can't be stored with ammonia or acid products because you get this poisonous chlorine gas. So it's got some disadvantages too. Another really common one you'll see are phenols. They are really good disinfectants, bactericidal, fungicidal, virucidal, and tuberculocidal, but not sporicidal. The one thing you really want to think about with phenols is that they are toxic and they are possibly carcinogenic. Do not use phenols anywhere near a nursery. So this is the thing we've learned over the last 10 years, that do not use phenols in nurseries. They also can remain very persistent in the environment, and because they are fairly toxic, disposal may be a little bit challenging for you. Iodophores, this is another disinfectant you'll be interested in. Again, it is not sporicidal. It's not particularly broad spectrum. And these get contaminated fairly easily. So you want to really watch that they're being used according to the label. And they're pretty expensive, too. But they're non-toxic and they're non-irritating. And so there are some advantages to using an iodophore. The quats, the quaternary ammonium compound, this is the one you're going to see a whole lot of. So your PDI sanicloths generally tend to be the quats or the caticides, some of those, again, combination products. The traditional, fourth generation, but the traditional ones were not generally tuberculocidal. So they have to be enhanced in order to get EPA registered for use against the BCG that we talked about earlier. They can be really easily contaminated with Pseudomonas, so keep that in mind. And again, not effective against C. difficile or the non-envelope viruses like norovirus, for example, and some of the gram-negative bacteria. Now, the new ones, the new fourth-generation quats, they are more effective and more broad spectrum. The other thing about quats is they don't work all that well in hard water. And if you use cotton or some of the microfibers, the quat will make those fibers really solid and hard, so they don't pick up as well. Now, the fourth generation ones are a little bit better, but you do want to ask about that. And also some of the quats can be a two-step in one process, so it will both clean and disinfect, particularly with those wipes. Hydrogen peroxide. So generally hydrogen peroxide does have some disinfectant qualities, but the unimproved or the non-activated or the non-accelerated hydrogen peroxide, they do kill a lot of germs, but it takes a long, long time. So keep that in mind. However, what everybody is using now are these improved hydrogen peroxides, and they have broad spectrum, really fast acting, and according to the studies we're seeing, they have the lowest toxicity. So they're really, really safe compared to so many of the other products that we use. But these are fairly expensive to use, so that's the other side you want to look at. So the ideal disinfectant. Now, this is a list of things you're going to look for when you are on your product evaluation committee. And again, none of these are going to satisfy every single one of them, but they do want to be broad spectrum and fast acting. You don't want it to be toxic. You want it to be compatible and play well with all your other products. You want it to have to be compatible with most of your surfaces. You want it to not have an unpleasant or offensive odor, because that's the first thing people are going to complain about is the odor. And it has to be stable, environmentally friendly, and economical. So if you can judge each of the products based on this on a scale, that's going to help you make your decision. All right, quick knowledge check. Are we ready for the poll? IPs should have a thorough understanding of the following when choosing a cleaning product. Now, this is 4 statements. 3 of them are correct. 1 of them is not, and they are numbered. So here we go. So as an IP, you should have an understanding of 1, differences among types and uses of disinfectants. 2, the manufacturing companies that produce and sell the disinfectants. 3, definitions of the terms cleaning, sanitizing, disinfecting, and sterilizing. Or 4, the manufacturer's recommendations for use, including dilution and contact time. So 3 of these 4 statements are correct. Which 3 that IPs need to have a thorough understanding of? All right, so while we're waiting for the poll to populate, the incorrect answer here is manufacturing companies that produce and sell disinfectants. So it may be nice to know who they are, but it's not critical. You do need to know, what are the pros and cons of the disinfectants that you're looking at. You need to know those terms that we had talked about earlier, cleaning, sanitizing, disinfecting. And you need to know what the manufacturer's guidelines say. So in this case, most of you, 94% of you, got that absolutely correct. So congratulations. All right, once more. During environmental rounds, you, the IP, notice that the housekeeper is cleaning up a blood spill on the floor. The best choice for cleaning blood and body fluids is A, alcohol, B, bleach, C, a phenolic, or D, a quaternary ammonium compound. So take a minute to answer that one. All right, so let's talk about these answers. So alcohol is pretty effective against blood and body fluids, but again, it's going to evaporate before you get a good kill time, particularly on the floor. Bleach is the correct answer to this question, and we'll come back to that in a minute. But the phenolic we're not going to use for a number of reasons. Mostly, remember, it's toxic, so it's not the best product. The quaternary ammonium compound, unless it's improved, it is not generally tuberculocidal, so it's not a good product for blood and body fluids. But bleach, in this case, is, of the four listed, this is the one that's most likely to be effective on blood spills. So it looks like we were split between the quat and the bleach. The quat, again, you want to check to make sure that it is useful against blood and body fluids. It may be, the label, it may be an improved product, but generally bleach is the preferred method for blood and body fluids. And you want to make sure that most of the blood is cleaned up prior to adding that disinfectant because, again, it can be inactivated in the presence of organic matter. Okay, good job, guys. All right, evaluation. So this is another thing that you're going to be responsible for probably is making sure that the cleaning is effective. So there are a couple of methods. Direct observation, that's probably the one that you're already doing. And this is you're going to do this because you want to make sure that it's being done systematically. The housekeepers are following their policies. You're going to work closely with the environmental services manager to make sure this is done. But it's not a great way of being very objective. That is, knowing that a surface is in fact disinfected because you can't see the pathogens. So there are some drawbacks. One is a Hawthorne effect. That's where people change their behavior just because they know that they're being observed. It can be really challenging logistically to be taking notes on all those surfaces. It's just a really complex process, so it's not the best way to do an objective evaluation. Now, you can think about environmental cultures. So if you really want to know exactly what's growing on the surfaces, you could swab. And it may be effective in an outbreak. So if you've put in some interventions to stop an outbreak and you want to make sure that that targeted organism is not present after you've done an intervention, you might want to do environmental cultures. That is a legitimate reason. But right now there aren't any studies that show that serially culturing the surfaces and providing feedback improves cleaning. I mean, it's just a really expensive way to do it. It can take weeks. You have to have a special environmental lab run those. And, there's still the breakpoint question, which is, how clean is clean? I mean, what level are you looking for? None, possibly. So not a great thing unless you're doing an outbreak investigation. This is a new one. This is fairly inexpensive, and that's the fluorescent marking of the surfaces. So the high-touch surfaces, you go in and you use this with a black light. So it's invisible to the naked eye, and you take the high-touch surfaces and you mark them, and then you come back and use the black light to see if the marks are still there. And if the marks are gone, then you make the reasonable assumption that at least that surface has been scrubbed. And of course, you can't make any assumption about the disinfection based on fluorescent marking. But this is really popular, and it is supported in the literature as being an effective method for improving room cleaning. But just know that there are some drawbacks. Like we hear a lot that the bed rails that have a little bit of a textured surface will retain the fluorescence, and so you can't really, it's hard to tell whether it was scrubbed or not because it's almost impossible to remove the gel. ATP is another really popular way of knowing this, but there's some drawbacks to this as well, and that is ATP measures organic material. So is the adenosine triphosphate present on the surface? But we don't know, really what the scale is. We don't know if that's dead bacteria, like it's non-viable, but it is still present. So does that mean the surface has been cleaned or not? So there's some drawbacks. The other thing is it's really expensive. So keep in mind if you're going to choose ATP as your standard, that you need to know what all of the costs are comprehensively. So keep that in mind. If you are going to use either fluorescent marking or the ATP, you need to think about how many rooms, how do you get a good sample size to know if your data are valid and reliable. And so in a small hospital like yours, you need to do at least 15 rooms on a regular basis. You establish a baseline, and then use a checklist to make sure that you're really systematically marking and collecting data. I know we're running out of time, so I'm just going to kind of go over these. Christy, our producer, you can pull it up, but I think what we may do is just move forward so we can get through the rest of this. The nursing director requests that the room surfaces be routinely environmentally cultured to ensure that they're clean. Your best response should be A, schedule routine culturing of the room so each is cultured at set intervals. B, the answer is routine culturing of the ICU is an effective way to provide objective feedback to environmental services staff. C, routine culturing should not be done because it is too expensive. Or D, routine environmental culturing should not be considered unless an epidemiologic investigation is being conducted. And as we talked about before, the correct answer on this one is D, that you in an outbreak situation you may want to culture, but again, it is expensive and it's not the best way to provide feedback. Some of the innovative technologies, I do want to talk about this before we run out of time. There are some things that we're seeing. Metal alloys like for hard surfaces, silver, copper. This technology really does seem to be helpful in reducing microbial counts and in reducing HAIs, but it's really expensive. So if you're redesigning renovating, you might want to consider some copper in either door handles, bed rails, that sort of thing. Also, there's some textiles, that's the soft surfaces that are now have antimicrobial properties like the privacy curtains that are lined with silver or triclosan or some of the quats. So you just want to make sure that those are EPA registered and that you know how they should be processed. That is going back to the manufacturer. So really exciting things going on with these surfaces. A new thing is the shark skin pattern. So on the hard surfaces, if it has little, like all these millions of little diamond-shaped patterns, they haven't yet been incorporated into healthcare, but it is an emerging technology that does appear to be antimicrobial. They think it prevents bacteria from colonizing because it requires too much energy by the bacteria to actually establish the colony. So that's pretty cool. The thing that everybody is really interested in is the UV light and the hydrogen peroxide fogging. For a long time, CDC said, don't fog your rooms. However, the newer hydrogen peroxide foggers may actually work quite well. There's quite a lot of studies. However, when you spray this dry mist of hydrogen peroxide, you do have to shut off your HVAC system, and you have to tape the grills, you have to tape under the door, and it can take a long time. So it's a lot of prep area, and the rooms cannot be occupied. And this fogging can take 2 to 5 hours. However, any supplies in the room, any complex equipment, the soft surfaces do get disinfected when you spray them with hydrogen peroxide fog. And the CDC has kind of backed off on their recommendation not to fog based on this new technology. So they aren't recommending it, but they have taken away the non-recommendation. Now, UV is also a fairly effective way to disinfect a room. There's non-touch. There's a lot of different ways, whether it's pulse xenon or UVC. Just be very careful when you listen to the salesman. You want to make sure that you're looking at many different products. Compare the the comprehensive cost. That's the cost up front plus all the supplies, plus the training, and just know that it can be fairly expensive. You still have to clean the rooms. For both fogging and UV, you have to clean the rooms because neither one of these will penetrate organic material, so that has to actually be physically removed. UV light will kill C. diff spores, as does the hydrogen peroxide. In this case, UV can take up to 50 minutes. The rest of the room can be done in 5 to 25 minutes, but this can take a while too. So be sure you know exactly how much time is going to be added to your terminal cleaning if you're going to use UV. Now, both of these technologies are really expensive. So we know that UV is about over $100,000 per unit. So it may not be an effective way for a small hospital like critical access hospitals to invest in unless you just have a raging problem with C. diff or some other infection, then you may want to consider doing it. But again, it's terminal cleaning, the room cannot be occupied, and you still have to clean the room, and you have to train your personnel. So think about that as well. Not saying it can't be done, but you want to think about it. Last knowledge check, which of the following could be a major drawback to using hydrogen peroxide? The answer to this one is that it lengthens the room turnover, right, because it takes a prolonged period, 2 to 5 hours. But it is effective in decontaminating the surfaces and the equipment that's in the room. And it doesn't seem to have any danger with the residue that goes along with it. So just to save some time. And so that's what I wanted to present with you today. I hope it was valuable and helpful. I know we're right at the top of the hour. If you guys want to stay on and ask a few questions, I'm here. You can also email me the questions. So Laura Shower says we purchased the hydrogen peroxide fogger for $10,000, and it does, I think that's dollars, and it does not take anywhere near as long as you're saying. That's great. So Laura, you might share that information with you. The information I got was from the literature and from the EQuIP text that was updated in 2015. So that's great. This technology is moving fast, and so I'm really glad to hear that the price is coming down and the time is shortening. So, Laura, feel free to share with us if you're interested, if others are interested. So, thank you. All right, thank you so much. I'm here to answer questions. We'll try. If I don't have the answers, we can reach out to some of the environmental services professionals. I hope it was valuable to you. And we will meet again next month where we're going to continue our series on the role of the environment. I'm trying to get a speaker who can talk much more about HVAC systems, water quality, and all of those other environmental impacts on infection. So join us next month, and thanks again.